Thank you. So as Rochelle mentioned, my name is Amanda Podolski, and I'm one of the medical oncologists over at Valley's Cancer Center. And today, as part of our overall, Breast Cancer Awareness Month in October, I'm going to talk to you about the screening guidelines in breast cancer. So just to start a little bit with basic statistics in oncology, or in breast cancer specifically. So 1 in 8 women will be diagnosed with breast cancer in their lifetime. And in a time frame, every 20 or every 2 minutes, a woman in the US will be diagnosed with breast cancer. So it clearly is a very high percentage of people, and it impacts a lot of people and their families. It's the most common breast cancer or cancer in women, except for skin cancer. In 2020, an estimated about 275,000 new cases of invasive breast cancer are expected to be diagnosed in the United States, along with about 50,000 new cases of a pre-breast cancer, or non-invasive, or like a stage 0 breast cancer. About 2,600 cases are expected to be diagnosed in men. So a man's risk is clearly much less than a woman. It's about 1 in 883 versus, as I said before, 1 in 8 women. Typically in men, the risk is usually associated with a genetic condition that predisposes them to get breast cancer. About 42,000 women in the US are expected to die in 2020 from breast cancer. The death rates have been pretty steady in women under 50 because usually the younger you're diagnosed, it tends to be a little bit more of an aggressive disease. But in women over 50, the death rates have continued to decline, and that's primarily due to screening guidelines and us testing and diagnosing early and the development of new treatments. More than 3.5 million women in the United States are women with history of breast cancer in the US. So when developing any type of screening guideline, it's just important to kind of be aware of the benefits and harms of screening. So we want to make sure that a person is not getting tested too frequently and that there's no harm associated with getting tested versus the benefits associated. So in a general screening test, you want to know what's the probability that this screening will detect a potentially fatal cancer early before the onset of symptoms, and that by detecting this cancer early, you're getting better health outcomes. So reduced death and more morbidity overall, as opposed to managing this cancer when a woman would have symptoms. And then the harms we want to limit, right? So it's what's the probability that this test will lead to a suspicious finding that will require further workup. So a woman might need a biopsy, but then the biopsy ends up not showing cancer. And what's the probability that those harms, you may be detecting a cancer that you didn't know you had, and it won't actually ever have any implications in a person's life. So if you're 95 and you get diagnosed with an early stage breast cancer, it probably won't have any implications for your overall longevity. So in terms of the screening guidelines, really they vary based on the different societies. The main differences tend to occur between the ages of 40 and 50, and whether or not to get yearly or every other year mammograms. So the American Cancer Society, which is usually what I would use for our guidelines, their recommendation is to start at age 45. So between the age 45 and 54 to get yearly mammograms. Between the ages of 40 to 44, from an average risk person, they can just discuss it with their healthcare provider, but there's no true strict guidelines to get mammograms. And then they say starting at age 55, you can consider doing it every other year, and you would continue getting mammograms as long as you're in good health. The National Comprehensive Cancer Network and the American College of Radiology, they feel that a woman should start screening at age 40 and to get it every year. And again, their recommendation is as long as a woman is in good health, which is the idea is that you should ideally be living 10 years or more after getting tested. The United States Preventative Services Task Force, which is guidelines that really guide a lot of primary care doctors, so really in the internal medicine world, they don't actually recommend screening until age 50, and they recommend every other year from age 50 to 74. Between age 40 and 49, again, it's similar to the American Cancer Society, but their cutoff extends a little bit longer. They're saying to discuss it with your healthcare provider, and you can decide it on an individual basis. There is data to suggest that if you go just by the USPSTF, which is the United States Preventive Service Task Force recommendations, that they can miss close to 6,500 to 10,000 breast cancers. They can miss about a third of cancer diagnosis and miss about 10,000 deaths per year. So clearly that's a high enough number that there might be more data to suggest that screening earlier is better. And then, as we're saying, that mammograms are clearly the main mechanism or main tool that we use to do screening. So what is a mammogram? It's low dose x-rays of the breast. And by doing regular mammograms, the idea is that you're going to be detecting breast cancer at an earlier stage. And women who get these regular mammograms are more likely to have breast cancer found both early and less likely to need aggressive therapy. So the difference would be potentially if you're finding something smaller, you can remove just part of the breast as a lumpectomy, as opposed to having to take off your entire breast as a mastectomy. And often if you're caught earlier, you often don't need chemotherapy and more likely to be cured. The caveat is that mammograms are not perfect. They can occasionally miss some cancers, and sometimes a woman is going to need additional tests to find out if something found on the mammogram is or is not cancer. So kind of, for those less familiar with mammograms, so in a mammogram itself, each breast is, compressed horizontally between two plates, and they flatten the breast tissue and they take two views of each breast. So it's 4 pictures in total. So this is the idea of in a normal mammogram, ideally there's your lobes and your ducts that you shouldn't see anything abnormal. Cancers, you might detect something that looks irregular. You may detect cysts or that are benign, and we can clearly tell based on the morphology on the imaging that it's not consistent with cancer, and calcifications, which might show that you're predisposed to developing things later on. So recently, there's been a more development of 3D mammograms. So what I was just discussing before with the 2 plates compressing and taking 4 pictures in total, those are 2D mammograms. So 3D is becoming more common, but it's still not universally available in all breast imaging centers. And many studies have found that 3D mammograms appear to lower the chance of being called back for follow-up testing. It seems to detect more breast cancers. It may be helpful in women who have very dense breasts, but I'll discuss that a little more later, and less likely to have false positives detected, meaning that you would have to go for a biopsy and it ends up not being cancer. The caveat here is that 3D mammograms often cost more than 2D mammograms, and this extra cost is not always covered by insurance. Usually the centers that have 3D mammograms and are providing it to patients will cover the cost themselves, and they sort of eat up the extra cost that might not be covered by the insurance, and a patient shouldn't have to pay out of pocket for those extra tests. As the insurance starts to develop new coding, it should hopefully be covered by more insurances. And again, the screening cost it's about 40% higher than a 2D mammogram, but hopefully the plan is that it will eventually be covered. There is also a concern that 3D mammograms have a little bit more radiation exposure. Newer software is being developed that will lower this and make it more equivalent to 2D mammograms. And the dose now that even is higher, it's safe and below the FDA cutoff for overall concerns of developing new cancers. So just a little imaging to sort of help compare the 2D mammograms to the 3D mammograms. I heard this analogy, which I found pretty helpful, is that if you think of a 2D mammogram, it's like looking at a book where you're looking at the front and the back. You're not really looking at or able to individually look at all the pages in between. Versus a 3D mammogram where you're able to open up and look at all the different pages and take each image individually. So in a 2D mammogram, as I had mentioned before, you sort of take the image from the top and side of each breast so that you're getting a single flat image that, as you notice here, can look, can be sometimes hard to notice if something here is actually cancer or not. You can obscure masses that might otherwise be seen. Versus a 3D mammogram kind of goes in an array, and it takes x-rays in 1 millimeter slices around the breast, and they're combined in a 3D view to then examine each slice. And so as we see here, we're more easily able to see a mass that we may otherwise have missed on the 2D mammogram. And in terms of a number of images itself, a 2D mammogram, as I had said before, is 4 images total, 2 of each breast. versus a 3D mammogram, which actually has about 200 images in total, so it's 100 of each. So clearly we're getting a lot more information from the 3D mammograms. So there was a large study that was actually published in one of the bigger journals in July of this year that was trying to compare the outcomes between 3D mammograms and 2D mammograms. And what they found is that the 3D imaging tended to decrease the rate of women being called back for another image by about 10%. And it also seemed to detect about 40% more invasive cancers as compared to the 2D. So not to get bogged down on graphs, but what this image is sort of showing you is that the B is for baseline and S is the subsequent, so a second image or more. And so what the differences that were really detected were primarily in the baseline imaging. So when the wider this line, that means there's a bigger difference detected. So it's really helpful to have the 3D mammogram as the initial test because it really helps make that differentiation between a true breast cancer versus something that is not concerning at all. Versus a second time imaging, getting a 2D versus a 3D didn't seem to have much difference. The other thing to note is that 2D, in this study, they looked at the density of women's breasts to see if 3D was that much more helpful than 2D for detecting cancer. And what they found is that with somebody with extremely dense breasts, so basically their whole breast is dense, there didn't seem to be that much benefit of a 3D, and other imaging modalities might be needed, versus a woman who has what's called heterogeneously dense breasts, so different spots that are more dense, but other areas that are not. The 3D seemed to be more helpful than a 2D mammogram. So what if you have very dense breasts and what's sort of the next step in terms of imaging? So a breast ultrasound is often used in women with very dense breasts, and it can often follow up an abnormal screening mammogram. A lot of times when we order mammograms, we'll order it with an ultrasound as needed, so the techs or the radiologist can determine if an ultrasound would be needed in this case. An ultrasound is often used and can detect early stage cancers that are not seen by mammogram. The caveat here is that there is an increased risk of false positives. So sometimes you will, again, have to have a biopsy because it tends to see things that often are not actually cancer. And it hasn't been shown to reduce breast cancer mortality. So it didn't seem that overall you have a survival advantage by doing routine breast ultrasounds in a woman. So just some nice high yield kind of points with the ideas. For every 1,000 women who have a screening mammogram, so 100 out of those 1,000, so 10% will end up having to go back for an additional mammogram or an ultrasound due to something that was seen on the first mammogram. 61 out of those 1,000 will have additional imaging and nothing is wrong. So really, if we're kind of subtracting here, it would be about 40 women might have something. 20 out of the 1,000 women will find that what was seen in imaging is probably not cancer, and they'll return in 6 months to keep watch on the findings. So we often use a tool or an imaging report will say something called BI-RADS. So a BI-RADS 3 is usually something that looks benign, but the radiologist will want you to come back in 6 months just to confirm there hasn't been any change to those imaging. 19 out of the 1,000 women will end up needing to have a biopsy. So, it's a nice percentage of women, close to 2%. And 5 out of those will end up actually being diagnosed with breast cancer. So it just shows that it clearly is an important tool. And when you do detect breast cancer in this way, there's a much higher cure rate than if you had a large mass that you felt when you were examining yourself. So what all of those guidelines that I had mentioned before are for women of average risk. But what about women who kind of fall into this higher risk category? So high risk tends to include those who have a lifetime risk of breast cancer of 20 to 25% or higher, versus, as I told you before, the standard risk is 1 in 8, so 12.5%, so basically double that risk. And we use different risk assessment tools to determine a woman's risk, and it's also primarily based on family history. If a woman has a known BRCA1 or BRCA2 mutation, so those are the common mutations that you hear about, that women often will have their breasts removed, so those women are at much higher risk. If you have a first-degree relative, so a parent, brother, sister, child, who has one of those known mutations, but you actually haven't been tested yourself, you're still within that high risk category, unless you do get tested and you're proven to not have those mutations. If you had radiation to your chest between the ages of 10 and 30, then you're also considered at much higher risk for developing breast cancer. Or if you have one of these conditions listed, not to get bogged down, or a first-degree relative with one of those syndromes, you're again considered in a high-risk category. So if you are in that high-risk category, the recommendation for most guidelines is to use a breast MRI along with a mammogram every year, and usually starting around age 30. So if an MRI is used, it's important to note that a mammogram is still needed on top of the MRI, because while an MRI might detect more cancer, it can still miss some cancers that a mammogram would note. And then in terms of a screening MRI for others, so what about people that don't necessarily fall into that really high risk category, but are still above the average risk? And those are women who have a personal history of breast cancer. If you've had a pre-invasive breast cancer, so this ductal carcinoma in situ or stage 0, or other abnormalities that have previously been detected via biopsy of the breast. So that's something called lobular carcinoma in situ. If you have atypical ductal hyperplasia, which is again abnormal cells noted within the duct, but they're not spread outside, or atypical lobular hyperplasia. So those women, there might be some more people would be in favor of thinking about getting MRI screening for those women, so that you don't miss something that a mammogram might not detect. And again, an MRI might be used in those who have, as noted before, extremely or heterogeneously dense breast that are seen on mammograms, so that the MRI can help differentiate problems seen. As I had said, that there are breast cancer risk assessment tools that we can use to sort of detect a woman's risk for breast cancer. The Gale risk model includes age, race, a family history of breast cancer, if you've had these prior biopsies with those abnormalities that I had just mentioned before, the age of first period, so the younger you were when you had your first period, the more estrogen exposure you've had, and therefore you're slightly increased risk to develop breast cancer. Again, the age of your first child, so if you were older at your first child and even younger with your first period, that provides you with more prolonged estrogen exposure, and the number of first-degree relatives with breast cancer. The model calculates a percentage of risk of breast cancer in about 5 years and also over one's lifetime when compared to a woman of average risk. And in those situations, if your 5-year risk is actually more than 1.7%, you might be a candidate for hormone therapy or anti-hormone therapy, really, to reduce your risk of breast cancer by about 50%. And just to kind of show you an example, this is the tool used from the National Cancer Institute, and you can click here and to try to assess your risk. It's a tool used only if you don't have these pre-invasive breast cancers and you don't have a family history. And then you can kind of go through and just to give you an example. Again, it can look at different race, the age, have you ever had a breast biopsy? So let's say we said yes, and you had one that was abnormal with some hyperplasia, you were young at your first period and over 30 when you had your first child and no family history. And then you click calculate risk, and it can show you within that 5-year time your risk versus the average risk, and again your lifetime risk versus the average risk as well. With that, I'll conclude kind of the talk on breast cancer screening and mammograms and open it up to questions. And just for your information, these are some helpful websites with guidelines if you wanted to read on things further.
Thank you so much, Dr. Podolski. Some of the questions that came in. The first one, how much radiation is in a stereotactic needle biopsy?
So a needle biopsy itself has pretty limited radiation. There's no concern that the biopsy itself would lead to increased risk of cancers. Typically, when a stereotactic biopsy is done either via ultrasound, which has almost no radiation or has no radiation exposure, versus on occasion it's with an MRI, which does have slightly more increased risk, but the percentage is low enough that there wouldn't be any concern that the biopsy itself would increase your risk.
Okay. And the other question we have from the attendee, can I lower my estrogen level somewhat through diet without aromatase meds following stage 0 DCIS surgery?
Yes, so there is evidence to say that in women who've had breast cancer, so either stage 0, more of the data is in stage 1 and further, but to decrease the risk of recurrence by eating a heart healthy or a diet that's rich in fruit and vegetables, low in red meat, low in alcohol, and typically, low in processed food, that there is some data to say that that will actually decrease your risk going forward. If for the stage 0 DCIS you had either a mastectomy or a lumpectomy with radiation, the goal of hormone therapy would really just be to reduce your risk of having a new breast cancer develop. And there's a lot of data to suggest that obesity and being overweight, that extra fat tissue actually increases the risk of breast cancer. So adjusting the diet is often something that we do recommend to patients with DCIS or even more advanced cancers to help decrease the risk of it coming back.
Okay. The other question is, does Valley have 2D or 3D?
So Valley can provide both. Often it has to be ordered as a 3D. So if you're getting it ordered by an outside primary care doctor or gynecologist, and to get it done at Valley, they often need to specify that they want a 3D image. On occasion, they'll have to confirm that it's covered by the insurance, but typically they can do either one.
Okay. Another question is, if ultrasound is ordered, if indicated, does that mean that the ultrasound gets done the same day or scheduled a different day?
Typically, if it's ordered as indicated, it will be done the same day. So they'll look at the breast, they'll decide if they need it, and they can do it at the same time. You won't need to have to come back for another image.
Okay. And then what is considered young age for a first period?
So typically, if you were less than 10 years old, that would be considered young. But I would emphasize that just having your period at a young age is not a risk in and of itself. It's sort of the combination of a lot of different things together that would increase your risk. So if you were 8 years old at your first period, you've had slightly more estrogen exposure. But if you had a child at 20, and if you then have no family history, have never had abnormalities, I wouldn't really put you in a higher risk category.
Okay. And then does the 3D mammogram identify cysts, fluid-filled cysts versus solid mass?
Yeah, so both the 2D and 3D are able to differentiate between a cyst and a mass. So cysts are usually never something that will need to be biopsied. It's usually we're able to differentiate enough via imaging. On a rare occasion, it might be something that looks semi-abnormal, but it's usually well demarcated. We can usually tell the difference between a fluid-filled versus a solid mass, and it can be on 2D versus 3D.
Okay. And then what are the recommendations for somebody who's male that has high history within the family of different types of cancer, including breast cancer? Do they recommend mammograms as well, and what age, etc.?
Yeah, so I think there is that idea that, yes, a man might be at increased risk because of family history. What I would recommend is sort of figuring out if the genetic testing had been done. I would say that in a man who has a family history of male breast cancer, then there would be more indication to do routine mammograms. But if there's only a history of female breast cancer and there's no BRCA1 or 2 mutation, there's no specific guidelines in terms of what the exact steps need to be done. And I would recommend, if there is a strong family history, to have genetic testing and talk to a genetic counselor, who are usually very helpful at telling you what exact steps need to be taken from a screening standpoint.
Okay. And at Valley, for genetic testing, how do do they have to go through a physician first before they get recommended for genetic consultation, or can they go directly?
So from my understanding, I'm not 100% sure, but I think they, at least from what we do, is we always are the ones who refer somebody to genetics. Your primary care doctor can probably make that referral as well. And it's been nice because they've actually, even during COVID, the way we've been testing a lot of the genetic testing is they do a virtual phone conversation to determine the risk and if genetic testing would be indicated. They would always confirm that your insurance will cover it because we don't want to ever test somebody and end up with a big bill that it wasn't covered. And then once the determination is that you qualify for genetic testing and it will be covered, they usually can then set you up to get the blood test done at one of our centers.
Perfect. And then one other question. I had a cyst that was biopsied, and then I was asked to return every 6 months. Does that ever get decreased to less frequency?
Yes. So often the younger a woman is, they more likely are having like fibrocystic breasts, which again, we get more frequent mammograms to make sure that we're not missing something by the cysts. Often as you get older, especially once going through menopause, your breasts tend to get less dense, or those cysts, which are often associated with your period, will go away, and then you can often then transition to yearly or every other year mammograms.
Perfect. Thank you so much, Dr. Podolski.
Of course.
Would you like to just mention anything else that you'd like to add, just to conclude?
Yeah, well, I guess just the one kind of thing to mention is I know COVID has made it slightly difficult to be getting, or people kind of have pushed off getting their screening tests. And what I would recommend is trying to still get them scheduled as you would normally. Our hope is that we don't end up seeing more advanced cancers because people have not been getting their screening tests. And there's starting to be more of a backup in terms of how, when you can actually schedule. So if you're not due until February, I would recommend scheduling it now for February, just to make sure that you don't then have to push it off further.
Thank you so much, Dr. Podolski.
Thank you.